Good afternoon, everyone. So welcome to this webinar. So as a very short introduction, my name is David Champredon, and I'm a researcher at York University in Toronto. My research focuses on understanding how infectious disease spread in populations, and I use mathematical models of disease transmission on a daily basis. And I'm working on many infectious diseases, including HIV. I also had the opportunity to work with epidemiologists, public health professionals, and clinicians to develop those epidemic models. So I kind of understand how confusing these epidemic models can be for non-specialists. So today, I will try to give you a good overview of how mathematical modeling can be used as a tool to support you to make decisions about health policy and programmatic work around HIV. And more specifically, this webinar is targeted to professionals who want to use mathematical model for their own work, with their own specific questions, but have no or little experience in HIV modeling. So I will also focus on the question addressed by the models, the data needed by these models, how to use and interpret the outputs of these simulations, okay, of the models, and also I will conclude with practical considerations. So this webinar is split in 3 main sections to address these goals. So some of you may or may not have already attended the first webinar, which covered mathematical modeling in more details. So I'm going to very quickly remind you of key concepts about mathematical models. Then we are going to look at 3 practical examples of HIV modeling studies that were published. Going through those examples will give you an idea of how other groups have done something that may be similar to what you may want to do. And finally, in the last section, I will deal with some practical considerations that you may want to have in mind before starting a modeling project. Okay, so first, mathematical models are made to give quantitative insights to a particular epidemiological question. So how they are made, right? So they usually simplify and translate the disease transmission process in equations. But very often, those equations are too difficult to solve manually, so we ask computers to solve them for us. So the results of the modeling analysis often come from simulations that were generated by a computer program, right? So it's, although we talk about math, there is a lot of computer involved. And the first webinar mentioned that there are various types of epidemic models, and choosing one type over the other is often driven by the question and the available data. Epidemic models are often thought in terms of supporting future decisions about policy or programmatic work and so on. But these models can also be very useful in understanding past and present epidemics, which can be equally valuable. Okay, but if there is only one message I would like to get across today about mathematical modeling, is that no matter how sophisticated the model is, if it is fed with poor quality data or erroneous assumptions, then the findings from this model are very likely to be incorrect too. So mathematical models are not a magic wand. This is just a tool that helps disentangle complex epidemiological mechanisms. And this tool can be very sensitive to the quality of its input. And that's something that I will keep on repeating during this webinar. Okay, so when you read the literature of HIV modeling studies, you roughly have 3 categories. So the first one addressed the problem that despite being fundamental epidemiological quantities, it is usually very difficult to observe HIV incidence as well as the sexual contact network where HIV spreads. So some studies use mathematical models to estimate poorly observed incidence and also infer the most likely contact network. So having a clearer picture of the past or present HIV epidemic can also be very valuable, for example, to support the design of future interventions. The second category of HIV modeling studies is concerned with projecting the impact of potential interventions on future HIV incidence. And finally, the third category are HIV modeling studies that have been developed to explicitly support the design of interventions as well as monitoring their implementation. So now I'm going to show you an example in each category. And the purpose of going through existing study is to give you an idea of how other groups have done something that may be similar to what you may want to do. So I will circulate the references of these papers after this webinar. So you will be able to go back to these studies and have a more detailed look. Okay, so the first example in this know your network, know your population category is this one. So, and in this study, the investigators wanted to understand what was driving the HIV incidence among MSM in Quebec. And so in all the examples we will go through today, I will highlight the question, the data, and the model used in that particular study. So here, at the bottom of this slide, you have the question, what drives the HIV incidence among MSM in Quebec? And as it is often the case in many settings, HIV sequences are routinely sampled from patients to test for potential drug resistance. So the researchers use these genetic data sets to reconstruct the most likely HIV transmission chains among these patients. And so how did they do that? So we have a database of HIV sequences sampled from the patients over the years. And here the database must have at least variables that uniquely identify the patients, for example, the social security number, the date of sample collection, and the HIV genetic sequence, right, the protein sequence. And the model that will reconstruct the transmission chains from genetic sequence is really complicated. And explaining it here is well beyond this webinar. Sorry. So, but the main idea is the following. If the two HIV sequences sampled from two patients are similar, then that means that there is likely a small number of steps between those two patients in the transmission chain. And that's because the model infers that the virus infecting both patients didn't have much time to mutate between infections. So the odds of the first patient having infected the second patient are larger. And conversely, if the two sequences are different, that means that a third individual was likely responsible to infect the second patient. So hence inferring the first and second patients are further apart in the transmission chain. So in this example, the HIV sequence sampled from patients A and B are very similar, whereas the sequence sampled from patient C is different. And I illustrate that with different colors. So the whole data set is given as an input to the model. And for example, a popular software to perform such an analysis is called BEAST, okay, if you want to look that up. And then, so you input these data sets into the model, and then the model is going to infer the most likely transmission chains. So in this example, one of the most likely transmission chain infers that patient A transmitted directly to patient B, whereas C is much further away from this transmission event. So this is how the most likely transmission networks can be reconstructed. So what can we learn from this type of models? For example, in this study, the model inferred the model inferred that large clusters that increasingly gain importance in driving HIV incidence from the early 2000s until today. And so such insights in the change of sexual contact network structure can have significant implication in terms of designing interventions or programmatic work and so on. But there is also another thing, is that the finding of this kind of modeling work that reconstructs the likely past and present population dynamics and network structure could be used to feed a second mathematical model that will, for example, project incidence. And you remember that I highlighted the importance of the quality of data inputs for models. And here, with this network reconstruction, we can significantly improve the quality of information that will be fed into an incidence projection model. Okay, so this is an important point here. Different type of models are made to study different type of questions, and you do not necessarily need to use only one single model to answer your question. So here, for example, the first model is designed to reconstruct chains of transmission and sexual networks. And then you can hook up a second different model that can be used to project incidence based on a given intervention. Okay? So now let's move on to a second example that uses actually this other type of model to project incidence. So in this second example, we have a study by a US group from Johns Hopkins that uses a mathematical model to investigate a relatively simple question. So, which is actually in the title of the paper, is what will it take to reduce HIV incidence in the United States? But their question is actually more focused as they consider what should be the screening and retention rates in order to halve HIV incidence by the year 2025. And here, their study is at the national scale. So unlike the previous example, that was rather on the state scale at the Canadian province, it is not possible to reconstruct the entire national sexual network. Okay? There is simply not the data, and even if you had the data, the model couldn't cope with that. So because we are at the national scale, it makes sense to use what we call a compartmental model, which was presented in the previous webinar. And a compartmental model is very different from the model that reconstructed the sexual network in the first example. And the data used here in the model are nationwide CDC estimates. So screening and retention rates depend on the social background and infection stage, and the model should incorporate this. So I'm not going to get into the details of this model, but just to give you a sense of the complexity and also the kind of data needed, here is a diagram of part of the model from the authors. And let me remind you briefly that in a compartmental model, you have to specify the proportion of individuals that belong to a given category or compartment, as we call that. And also the rate at which these individuals enter and leave a given categories. So these are the arrows in this diagram. So for example, in this particular case, how many HIV-infected individuals are linked to care in any given month. And that we need that kind of information for different stage of infections. how many will be treated? What is the proportion of HIV-infected Americans that are in early infection stage, and so on and so on and so on. Right? You have a lot of parameters to inform, and that's actually informing many parameters for a model is something that we have to deal with when we model epidemics. And so you can categorize model parameters in three broad types. You have what I would call the well-known parameters. So, for example, the age structure of the population. Okay, that's something that is usually well known. Prevalence, to a certain extent, could be also considered as well known. So these are data that can inform directly the model, okay, from whatever you have available. Then you have what I'm calling uncertain parameters, the ones that are not or poorly observed, and that can be fitted to related data. So, for example, the transmission probability per sex act is not directly observed, but we need that sometimes in the models. And this probability of transmission per sex act is linked to incidence. So, we could infer this probability from incidence data, for example. So it's an indirect way to gather information about a specific parameter. An alternative is to use estimates from the literature that may or may not be fully relevant to your particular study. And in this case, systematic reviews and meta-analysis are particularly useful. And then you have what I call the focal parameters. So these are the parameters that your study focuses on. So in this example of the article, the focal parameters are the screening and retention rates. So these parameters are explored with what we call a sensitivity analysis. And a sensitivity analysis is a fancy way to say that because we don't know the values of these key parameters, we scramble their values within a broad range. So in this table from the authors, you can see that, for example, the retention rate, which is the first line, so the retention rate used in the model had a baseline value of 86–89% per year. And they explored what effect it will have on HIV incidence if the retention rates is going to be between 50 and 99%. So concretely, okay, this is how propagating uncertainty looks like. So you scramble all the parameters at the same time within broad ranges. So this way, you generate thousands of scenarios with different values for uncertain and focal parameters. So the model runs a simulation for each scenario, okay? Each scenario has a different value for the focal parameters. So for example, the first line here, we run a simulation, the model ran a simulation with a retention rate of 52%, a screen rate of 1%, and you have other parameters. For example, adherence to treatment was set 57%, and so on and so on. So these are your input parameters. And then, so each scenario simulates your key metric. So that is here, it's the HIV cumulative incidence up to the year 2025. And this is the column on the right. And here, in this table, I highlighted the scenarios that reach the goal of reducing the cumulative incidence by at least 50%. Okay, so that was one of the main goals by the study we are looking at now. So then by knowing that this is a successful scenario, for example, scenario 2 and 5 are the scenarios that are successful, you can look back at the parameters and record their values and say, okay, if I have a retention rate of 59%, screening rate of 38%, an adherence treatment of 17%, and so on, then my goal of reducing HIV incidence by half is likely to work. Okay, And so this is what the authors did, okay? So, I mean, the previous slide is something I made up. And here we have the actual results from the study. So here, for example, they look at the rate of disengagement from care, and what they had as a result of all this simulation is that if this disengagement rate from care is less than 5%, then you have about a 55% chance to reduce HIV incidence by half, okay? On the y-axis, you have the percentage of the simulation that met this goal of reducing HIV by half. And yeah, and also if this rate is higher than 15%, there's basically no chance of a successful outcome. Okay, so this is the kind of result that you would like your model to give you. Now, if we look at another of the author's results, we can also identify focal parameters that are not important in achieving the intervention goal. Okay, so knowing what's important and knowing what's not important, I mean, for me, it's equally interesting. So for example, here, they looked at the frequency of screening among low-risk group, and this, they concluded that it has barely any effect on the probability to halve HIV incidence by the year 2025. Because this probability remains at around 7%, despite varying dramatically the frequency from once every 10 years to approximately once per year, okay? So intervention efforts, so when you look at this graph, intervention efforts should probably not be concentrated on screening low-risk group, okay? So that's one of the kind of results you can have from the model. And let me take the opportunity of this type of result to emphasize the importance of mathematical models giving results in a probabilistic way, with this kind of percentage of simulation meeting the incidence target. Saying that that parameter value should be exactly X or incidence will be exactly Y is always overconfident. Okay. Mathematical models can and should propagate uncertainty and communicate results with probabilities or confidence interval, right? So that study really illustrates that. Okay, so now we are going to look at a third modeling study that was a key part in designing a clinical trial. And although it's about a clinical trial, most of these could be applicable to other types of interventions. Okay? So this clinical trial took place in 21 clusters in Zambia and South Africa. And the study, I mean, the clinical trial had 3 arms. You had arm A, which had the most intervention, where you had increased counseling to the participant. They also promoted male circumcision, and treatment was given irrespective of the CD4 count. Then in arm B, participant had also increased counseling, but there was no particular effort to have male circumcisions, and the antiretroviral therapy, was given if the CD4 counts was below 350 only. And then you had the third arm, arm C, which was the control group. So a participant in that group received the national standard of care that they were given. And the primary endpoint was the cumulative incidence 3 years after the start of that intervention, after the start of that trial. And the model was a key component in designing this trial. So the investigator wanted to make sure that, considering what we already know about population behavior of the participants, the current state of the HIV epidemic, the intrinsic effect of antiretroviral therapy, of circumcision, okay, what would be like? Would we be likely to see an effect between those three arms after 3 years? So, in other words, you really want to avoid making mistakes in the design of your multi-million-dollar trial. So, the investigators made a mathematical model that replicated both the intended design of the clinical trial and the participant populations. It is a fairly complex model, again, and we won't have time to get into very much details in this webinar. But again, I want to emphasize the kind of inventory that must be made regarding the parameters of the model. Okay, so here on the right-hand side, you have a figure, one of the diagrams describing the model in the article, and it's fairly complex. And you have, a lot of compartments, a lot of, rates you have to estimate. And this inventory of parameter is done not only by modelers, but also with the support of epidemiologists and clinicians. And here, for example, you need to know what are the a priori effects of treatments, circumcisions, whether there are any behavioral differences between the 21 communities, the 21 clusters targeted by this trial, et cetera, right? So once this inventory is made and the relevant data sets are identified, your model should be a fairly good representation of the real world. And running the simulation of future HIV incidence in each arm should give you a fair representation of what the trial will do. So now, let's see what the simulations of this study, the results, tell us. And in particular, how likely will this trial be able to see the effects? Okay. So on this first figure, we see that the average prevalence of the simulations, which is represented by the black line, goes right through the observed HIV prevalence over the past 20 years. And this observed prevalence is represented by the gray points and the vertical segments that represent the confidence interval of these observations. Because it goes, so we can see that the black curve goes right through these gray points. So the model is fitted to observed prevalence. And it can, so what it means that the model can replicate the past trajectory of the epidemic in the participant population. Okay, so that's the left-hand side of this figure. Then you have the vertical dashed line that represents the present time. And the three curves beyond that, okay, the black, blue, and red, represent the simulated prevalence for each arm. So we can see that indeed, arm A, the arm which has the highest level of intervention, has the steepest decline of HIV prevalence. But what's even more interesting in the case of this intervention is this figure on the right-hand side that tells us how likely it is that we will indeed see a difference between arm A and arm B. The red histogram on the right-hand side shows us the distribution of the reduction in cumulative incidence after 3 years in arm A, okay, with all the parameters values sampled from a broad range. So, like the the slide I showed you earlier. And similarly, the blue histogram shows the distribution of incidence reduction for arm B. So what's interesting here is that these two distributions overlap. That means that there is a chance that we may see a reduction in incidence in arm A that will be smaller than the one in arm B, okay? Despite the fact that A has more interventions. And here, the size of this overlap is relatively small. So that means that there is only a small risk that this may happen. So you can then adjust the design of your trial or interventions in order to minimize this risk, the risk that these two distributions overlaps. So, and when they overlap, that means that you don't really see a clear effect. So you're going to play with the parameters of your model, for example, the intensity of intervention in each arm, in order to fine-tune the design of your actual, the real trial. Okay? So the approach in this paper that we've just seen can be used, so not only for clinical trials in Africa, but also to test programs in the US at different levels, okay? At the city level, at the county level, at the state level. Okay? This type of study shows that mathematical models can really be a key part in the design of programmatic interventions or public health campaign in order to maximize the chances of a positive outcome or a sound design of the intervention. So now let's wrap up what we have seen with all these examples. So in a mathematical modeling project, your question drives everything. And next, the data available will also shape how the model will be made. So you, as a public health professional, will be a key person by providing, well, first the question, and very often also the data, or part of the data. So it is really critical that the question is defined as clearly as possible. And as we saw in all the examples today, the epidemiological question addressed by the model was always clearly defined. What is the perimeter of the population studies? MSM in Quebec, participant in a trial, and so on. Is there an intervention? No, yes. If there is an intervention, describe it in details, okay, as much as possible, because that's what we are going to model. Is there, for example, a geographical component to your question? Because then, including spatial element in a model is also like a step in complexity, a step up in complexity, and so on and so on. So, question and data available is really, I would say, the key part of a modeling project. Then, depending on the data, it can be very useful to do a brief data analysis. So not like a full-fledged model, but visualizing, in a different angle your data, a very short data analysis. Because sometimes you can have unexpected findings at this early stage that can then feed back to reshape your initial questions. Okay, so sometimes by just simply looking a little bit in details at the data, you can have surprises. So once the question and available data are clearly defined, then we can start implementing the model. And once the model is implemented, and most of the time it implies writing computer programs, you have the first results, okay, that need to be validated not only by the modeler, okay, to spot some bugs or obvious coding mistakes, but also by public health professionals or clinicians to validate and interpret these first results from a practical angle. Okay? So not from the modeling point, but really from a practical angle, epidemiological angle or public health and so on. And here again, at this step, you can look back to reshape your initial question. Okay, so the first results often reshape the first question, more or less, but this can happen. And then finally, once everyone believes the data and that both the data and the model are trustworthy, then we can look at the final results, interpret and validate them, and ultimately publish some kind of a report, right? So these are really the key steps in a modeling project. Okay, so at this stage, I hope that you have a better idea of what type of practical questions a model can address, but we've just seen a really small subset of what is possible. But still, and what type of data goes in the model, and how the output look like, and how they could help you taking programmatic and policy decisions. And now, let me brush a broad picture of some other practical considerations around mathematical modeling that can be really critical in the success of such projects. So, who is going to make the model? And here I see like 3 possibilities that are not necessarily mutually excluding. So first, you may have internal resources already, colleagues that are or have been involved in scientific modeling. So this option can be appealing, especially if you are dealing with a sensitive data that is hard to send outside. Another option, which is probably the most prevalent, is to team up with one or more academic groups. There may already be existing or natural collaboration with your institution, with other universities or colleges. And consulting is probably a less popular option, but if you have time constraint, it may be an option to consider. Okay? But that's usually rare. Okay, so how long does a typical modeling project take? Well, let's not forget that that epidemic modeling is still an area of research, and it's not that obvious that a model can be taken off the shelves to address your specific problem. So timing may be uncertain. But however, I would say that the typical range is between a month, which is relatively short, to a year. But again, it really depends on the questions, on the data available, and the type of collaborators you are going to work with. Okay, so let's assume that you have the internal resources to conduct a modeling project. So do you need a specific software? Well, again, it depends on how complex the model should be based on your research question. But I would say there is no rule. This is principally based on the preferences of the modelers. If your model happens to be simple enough to be implemented in a spreadsheet, and for example, getting other software is not feasible, then using Excel may be a solution. And I can give examples. You can send out examples that do that. And else you have many options out there, either free or commercial ones, and they can be equally good. Again, it really depends on your own constraints. Legal considerations can be very important. So this is usually driven by data privacy, in my experience. And depending on your institution, and also the modeler's institution, that process can be more or less tedious. There are ways to make this legal/privacy process smoother. So for example, most of the time, models do not need identifiable information, like the name of the patient, their social security numbers, even birthday and so on. All this information is usually not necessary at all for the mathematical modeling. So anonymizing the data upstream, before any modeler can see it, is probably always a good idea. And there are also ways to do that with simple spreadsheets. I mean, I can also circulate some spreadsheets if you want that can give you an idea of how this is done. You can also have the modelers make a software that runs locally in your institution, such that the data never leave your offices. So if you are curious about how this can be done, okay, you can contact me after this webinar, and I'll be happy to talk about this in more details. And finally, probably the most important item is the cost. And again, how much a modeling project will cost you really depends on the specifics of the project and your institution. You can have no financial cost if you manage to have, for example, graduate students that are already funded by their universities and just happen to be very happy to be, and their supervisor also is happy to be working on your project. But again, there is a broad spectrum of costs within a modeling project. If you have to pay a postdoctoral researcher for a year or two, that can be expensive. Okay, so to wrap up, I would say that again, your question will be a key driver to the model design. So, and what I mean by model design is how complex the model will be, what kind of data we will need, and how much time it will take, and so on. The data, so again, the input data in the model is really critical, and you really want to make sure you have good quality data that is going to be fed into your model such that the results are going to be trustworthy. The model should propagate uncertainty. So the question is more like how likely this outcome is, whether that the outcome is exactly going to be 57% or like that. And yeah, I would advise to really plan and budget ahead. These are the practical considerations that I mentioned in the last slide, because you don't want that kind of project to spiral into like an unmanageable, very long project that is going to be difficult to handle. So planning is really key in this kind of project. And I'm done. So thank you very much for your attention, and I'm happy to take any questions you have. I've also put my email if you want to contact me, if you have other questions that we're going to cover during the next 10-15 minutes. So, yeah.
Great. Thank you so much for that presentation, David. So again, as a reminder, if you have questions, you can either put them in the chat, or I can unmute your line if you prefer to speak then. We do have one question already from Nicole that came in about halfway through your presentation about, I'll just read the question verbatim. She said it would be difficult to have an ART adherence of 60% with a retention of 10%. Shouldn't a model exclude logically inconsistent scenarios?
Oh yes, of course. No, I mean, yeah, I should have made it clearer that what I showed on the slides, I mean, I guess this is a reference to that slide here. I just put some random numbers, so I apologize. I should have been clearer here. But yes, here it's just to illustrate how the process works. So, and indeed, yes, I mean, that's actually a very good question. If the model, or maybe the data that are going to be fed in, should include only the most likely scenarios. Okay, so yes, whatever I wrote down here that doesn't make sense shouldn't be fed into a model. Sure. Again, it was purely for an illustration purpose, and that's not.
Thank you.
And that's not from the paper, right? I made this table up to illustrate.
Okay, great. I will unmute all the lines in case anyone wants to say their question right now.
Now, you and Brandon need to get to talking. I don't know how y'all gonna get to talking. I'm gonna let you figure.
Okay, if there are no questions currently, please feel free to email either me or David your question if something comes to you later. I can pass those questions along. If you would like any of the resources that he offered during the webinar, I'm sure I can pass those along as well.
Sit down and talk about what
I'm going to
upset about.
Post in the chat now a link to the webinar evaluation. If you could all please take a moment to fill that out, that would be very helpful. But thank you so much, David, for that wonderful presentation. That was very helpful. And thank you all for attending.
Okay, thank you. Goodbye.
Great. Have a good day, everyone.
I just wish she gone by her business. I wish her husband come on home so she could buy her business and leave everybody else's business.